Hi, my name is Jamie Riddell. I'm a neonatal nurse practitioner with Seattle Children's Hospital, and I've been working here at Providence since 1996. I started as a LPN and just worked my way up through the ranks, so I've done everything from LPN to RN to nurse practitioner. I understand that education really helps us do a better job, and so we really want to talk today about the late preterm policy that encompasses ages 34 and 0.7 weeks to 36 and 6/7 weeks. For the purpose of this education, we're going to focus on babies 35 weeks and greater because the goal of this education is to try and keep those babies with their families. In the past, we have had those babies admitted to the NICU for at least 24 hours, which separates the mother-baby bond. It also makes breastfeeding more difficult and the establishment of milk more difficult. So our goal is to try and keep those babies with their mothers with some increased surveillance and heightened monitoring, allowing them to be able to stay with their families. Respiratory morbidities are also increased in the preterm infant. These can include transient tachypnea of the newborn, respiratory distress syndrome, or respiratory failure and apnea. It's very important to realize that preterm baby lung development occurs past 34 to 36 weeks, and although we usually consider 34 weeks for lung maturity, in general, the alveolar sacs and the terminal alveoli in the preterm lung continue to develop after the 36-week mark. We usually think of 34 weeks as that big surfactant surge in preterm babies, but there are babies who that is delayed in, and if born at 35 weeks, they may have missed that surfactant surge. So the babies are at increased risk for respiratory issues, as well as increased risk for needing respiratory interventions at delivery. It's very important to make sure that the correct staff are present and that NRP is followed, and that we just make sure that we've established a stable respiratory effort and rate prior to leaving the baby with their family. The first couple of hours are very important and most important in monitoring the baby's respiratory status. In most cases, if a baby's going to have trouble respiratory-wise, it's going to be in the first 2 hours of life. A baby who is borderline saturated, saturating in the 85 to 90 range, would still appear pink, but might have more trouble with transition to extrauterine life and might be at higher risk for persistent pulmonary hypertension, which is essentially just fetal circulation that has not transitioned. Those babies can get very sick, and some of the highest risk for PPHN is in the late preterm infant. So as we discussed, ensure that the NICU team assesses the baby prior to being dismissed after delivery. Again, early intervention goes a long way to prevent long-term complications or readmission within a couple of hours of delivery. So just let the NICU team assess that baby before they're dismissed. The other things that are really important to do are to get the baby into skin as much as possible and soon after delivery. This will help stabilize their respiratory status, will help stabilize their oxygenation and their heart rate. If you have any concern about their vital signs, that maybe they're tachypnic, maybe they don't appear very pink, maybe they're mottled, any of those issues, or if they're grunting, flaring, make sure you get a pulse oximetry reading. That gives you a lot of information about how the baby's doing. Be mindful that if the baby does have some degree of PPHN or just hasn't transitioned completely, the best place to put the pulse oximetry is on that right hand. You can take a pulse oximetry reading on other extremities, of course, but be aware that if the reading is low or the extremities are very cool, it's very important to go to that right hand. So when you get your pulse oximetry reading, if the baby is having any respiratory distress, making sure that you're talking with the licensed independent practitioner or the physician about what you're finding. A normal saturation range for a baby within the first couple of hours of life is really just greater than 90%. We would expect a baby to be 95 or greater going forward within a couple of hours of birth, but the transitional period, as long as they're satting greater than 90, is very acceptable. If you have a baby who's dipping down to the 88, 89 range, it actually probably does warrant you discussing that with the LIP, just because that probably takes warrants some more monitoring and maybe even down in the NICU. And that's increasingly true if there's some respiratory distress. So transition oftentimes looks like a baby who is a little tachypnic, might be flaring a little bit, might be having a little bit of retractions, but looks very comfortable breathing and is satting 90 or better. That's pretty normal for a couple of hours after birth. But if you have a baby who looks like they're uncomfortable or they're desaturated, 85, 84, less than 88%, they look like they're having trouble breathing, that is definitely something to talk with the LIP about or call a rapid response. Very important is adequate positioning. So as you can imagine, these preterm babies might have some issues with neck control. They might have, their heads are going to be larger than their body can support perhaps. They don't have a lot of upper chest and body wall support. So making sure that you're teaching the families to position those babies well, that they're not up on the family's chest with their head kinked under, making sure that airway's nice and open. When they are in their crib or in skin to skin, that they're well positioned, making sure that airway's open. And that goes for going home as well, teaching them good positioning, back to sleep, all those things, because late preterm infants are at higher risk for apnea, especially during a deep sleep cycle, as well as obstruction. Late preterm infants are at higher risk for SIDS, and so educating families on important good positioning, safe sleep practices, no use of tobacco, things like that are really important to start early on. Make sure we're modeling those in the hospital as well.